What I am about to explain may completely change the way you think about every blood pressure pill sitting in your medicine cabinet right now. Because if you are taking amlodipine, losartan, or lisinopril, there is a very real chance that a symptom you have been dismissing as just aging, just stress, just poor sleep, or just a rough patch is actually your body trying to warn you that your medication is affecting you in a way that was never fully explained. And that is the part that concerns me most. People do not usually get hurt by these medications because they were prescribed recklessly. They get hurt because they do not understand what the medication is actually doing inside their body. They miss the early clues. They normalize symptoms that should not be normalized. And by the time something serious develops, the warning signs have been sitting in plain sight for weeks or months. I am Dr. Emily, and if you have been prescribed amlodipine, losartan, or lisinopril to manage your blood pressure, there are 11 things you need to understand right now. Not because your doctor is hiding anything from you, but because most appointments are too short, most explanations are too rushed, and most patients leave holding a prescription bottle and only half the information they actually need to use that medication safely. By the time we finish, you are going to understand which side effects are common, which ones are genuinely dangerous, which ones sound harmless but absolutely are not, and why the most important truth of all has nothing to do with the number on your blood pressure monitor, and everything to do with whether you can safely stay on the medication long-term. Let me start with Margaret, because her story explains exactly why this conversation matters so much. Margaret was 72 years old, organized, disciplined, the kind of patient every clinician hopes for. She took her medicine exactly as prescribed. She kept every follow-up appointment. She never skipped a single dose. Her blood pressure improved beautifully on paper. Everything looked perfect. But 3 months later, she was sitting in my office telling me her shoes no longer fit. Her ankles looked puffy every evening. She felt strangely heavy by bedtime. She thought she was gaining weight. Her daughter thought maybe it was her heart. Margaret was terrified. And what nobody had fully explained to her was that the medication doing the right thing for her blood pressure was also causing a very specific side effect that can fool people into thinking something else entirely is wrong. That brings us to the first thing most people never hear explained clearly enough. These 3 medications are not interchangeable pills wearing different labels. They belong to completely different classes of drugs. They work through completely different mechanisms, and they produce completely different patterns of side effects. Amlodipine is a calcium channel blocker. Losartan is an angiotensin receptor blocker. Lisinopril is an ACE inhibitor. All 3 lower blood pressure, yes, but the way each one accomplishes that goal inside your body is fundamentally different. And that difference determines what kind of side effects you are most likely to experience. If you do not understand which class your medication belongs to, you will misread what your body is telling you. You will assume all blood pressure medicines work the same way and produce the same problems. They do not. Amlodipine tends to relax blood vessels in a way that commonly causes swelling in the lower legs. Lisinopril is well known for producing a dry, persistent cough. Losartan is often chosen specifically when someone cannot tolerate that cough. Same goal, different pathway, different clues. And here is why that distinction matters more than most people realize. If you start coughing on lisinopril and assume it means all blood pressure medications will make you cough, you might stop treatment entirely. If you develop swelling on amlodipine and assume your heart is failing, you might panic unnecessarily. If you feel fine on losartan and assume there is nothing to monitor, you might miss a potassium problem building quietly in the background. The name on the bottle tells you the class. The class tells you the pattern. Once you understand the pattern, you stop being blindsided by symptoms. And once you stop being blindsided, you make better decisions faster. That single piece of understanding can prevent a manageable side effect from escalating into a medical emergency. Now, let's talk about the side effect Margaret was living through without knowing it. Amlodipine can cause ankle and leg swelling, and this swelling is one of the most misunderstood side effects in all of blood pressure medicine. People assume it means they ate too much salt. They think they are retaining water because of weak kidneys. They think they are becoming less active and putting on weight. But with amlodipine, the swelling often happens because the medication relaxes the small arteries more than it relaxes the veins. Blood flows down into the legs more easily than it flows back up. Pressure builds in the tiny vessels. Fluids start seeping into the tissues around the ankles and feet. That is why people on amlodipine often say they feel fine in the morning, but by evening their socks are leaving deep marks. Let me tell you about Arthur. He was 76, and every afternoon his ankles looked noticeably larger than they had in the morning. He assumed it was just part of getting older. He started sleeping with his legs propped up and noticed the swelling improved overnight, only to return by the next afternoon. He never connected it to the amlodipine he had started 6 weeks earlier. What made this dangerous was not the swelling itself, it was the silence around it. He did not want to bother his doctor. He kept taking the medication, kept getting more uncomfortable, and eventually started skipping doses on days he wanted to go out because he was embarrassed by how his legs looked. That is exactly how a manageable side effect turns into uncontrolled blood pressure. The swelling may not mean the drug is wrong forever, but it absolutely means the conversation needs to happen. The next issue catches people off guard because it does not always show up right away. Lisinopril can cause a dry, persistent, nagging cough. And what most people do not realize is that this cough does not always begin within the first few days. Sometimes it appears weeks later. Sometimes it takes months to develop. And because of that delay, people rarely connect it to the medication. They blame allergy season, dust in the house, acid reflux, a lingering cold, dry winter air. The cough usually feels scratchy, irritating, stubborn, not wet, not productive, not dramatic, just relentless. And because it often gets worse at night, people assume their lungs are the problem, when the real culprit is the pill they take every morning. Helen was 69. 4 months after starting Lisinopril, she developed a tickle in her throat that would not go away. Then came the nighttime coughing fits. Her sleep deteriorated. Her energy dropped. She started waking up exhausted and assumed she was just getting older. Or maybe her reflux had returned. She bought lozenges, changed detergents, replaced the air filter in her home. Nothing helped. When I asked her when the cough started relative to the medication, she looked stunned. She had never been told that the Lisinopril cough can arrive late. And once the connection was explained, everything clicked into place. This matters because many patients quietly suffer with that cough for months. Some eventually stop the medication on their own without telling anyone. And that is exactly the outcome we want to prevent. But there is something even more important hiding behind this, and it needs to be said clearly. A dry cough on Lisinopril is usually irritating but not dangerous. The symptom that demands emergency attention is swelling of the lips, tongue, face, or throat, especially if breathing or swallowing becomes difficult. That is not a wait-and-see situation. That is not a call the office on Monday situation. That requires immediate emergency care. ACE inhibitors like Lisinopril can in rare cases cause angioedema, which can become life-threatening very quickly. ARBs like Losartan can very rarely be associated with similar reactions as well, but the classic concern is with ACE inhibitors. So if the issue is cough, do not panic. If the issue is facial or throat swelling with breathing difficulty, move fast. The next issue hides in plain sight in the grocery store. If you take Losartan or Lisinopril, potassium matters far more than most people realize. Most people hear that and think they are safe because they do not take potassium supplements. But potassium does not only come in pill form. It shows up in salt substitutes, heart-healthy seasoning blends, electrolyte powders, meal replacement drinks, and over-the-counter products people use without thinking twice. Both Losartan and Lisinopril can raise potassium levels, and when potassium climbs too high, it affects the electrical rhythm of the heart. It may not announce itself loudly at first. It may show up as weakness, muscle cramps, tingling, fatigue, palpitations, or sometimes hardly any symptoms at all. Robert was 74 and had been trying hard to improve his health. He cut sodium, started reading labels carefully, and proudly switched to a salt substitute because he thought he was doing exactly what his heart needed. What he did not realize was that many salt substitutes replace sodium with potassium. So now he was taking Losartan, which can raise potassium, and seasoning every meal with additional potassium on top of that. He started feeling weak and slightly off. He noticed occasional skipped beats in his chest. By the time his labs were checked, his potassium was high enough to require immediate attention. The tragedy is that Robert was not careless. He was trying to do everything right. Nobody had simply connected the dots for him. And that gap in education is exactly where patients get hurt. The next issue confuses people so badly that some stop their medication at the worst possible time. Losartan and lisinopril are not just blood pressure drugs. In the right patient, they can also help protect the kidneys and the heart over time. But when you first start them or when the dose is increased, early blood work may show a small change in kidney function, a slight rise in creatinine, a small dip in eGFR. To many patients, that sounds like proof the medication is causing kidney damage. And sometimes a significant change does require attention. But sometimes a small early shift is expected because these medications change the pressure dynamics inside the kidney's filtering system. That is why blood tests matter and why guessing is so dangerous. Sharon was 71 and had both high blood pressure and early kidney disease. Her doctor started lisinopril specifically because it could help protect her kidneys long-term. A couple of weeks later, her labs changed slightly. She saw the results in her online patient portal before anyone called her, panicked, and decided the medicine must be hurting her kidneys. She was one click away from stopping it entirely. When we spoke that evening, I explained that the key question was not simply whether the number moved. The key question was how much it moved, what the trends showed, and what else was happening in the body at the same time. A mild expected change under clinical supervision is very different from a dangerous decline. That is why lab follow-up is not optional. It is part of the treatment itself. These medications are powerful and useful, but only when they are monitored properly. And that leads directly to one of the most overlooked dangers for older adults. Dehydration changes everything. If you are taking Losartan or lisinopril and then develop vomiting, diarrhea, a stomach virus, poor appetite, or heavy sweating in hot weather, the medication that was helping you yesterday may hit you very differently today. Your blood pressure can fall too low. Your kidneys can become stressed. You can feel dizzy, weak, or faint. In some cases, you can develop acute kidney problems faster than you would expect. The medication did not suddenly become dangerous. Your body's fluid balance changed, and now the same dose is operating in a completely different internal environment. This is one of the most important "nobody told me" moments in blood pressure care. People keep taking the same pills through illnesses that dramatically alter their hydration, and nobody ever gave them a sick day plan. Frank was 78 when this caught up with him. He had a bad stomach virus. He could not keep much down. But he still took his usual Losartan every morning because he was proud that he never missed medication. That night, he stood up from the couch, the room spun, and he nearly collapsed. In the emergency department, the problem was not that Losartan was a bad drug. The problem was that his body was depleted. He had lost fluids. His blood pressure had bottomed out. His kidneys were under strain. What he needed was not blind obedience to the pill bottle. He needed to know when illness changes the rules and when to call for guidance instead of powering through. That kind of practical advice is not dramatic, but it prevents real suffering. The next issue sits in millions of medicine cabinets and has nothing to do with prescription drugs at first glance. Ibuprofen, naproxen, over-the-counter anti-inflammatory pain relievers that people take for back pain, knee pain, arthritis, weekend gardening soreness. If you are taking lisinopril or Losartan, especially if you also take a diuretic, regular use of certain anti-inflammatory pain medicines can create what has sometimes been called a perfect storm for the kidneys. This interaction catches patients off guard because every individual piece seems ordinary. A blood pressure pill, a pain reliever, maybe a water pill. Nothing sounds dangerous on its own, but together, in the wrong situation, especially with dehydration added in, they can reduce blood flow to the kidneys and increase the risk of kidney injury. And most people never mention their over-the-counter pain medicine to their doctor because they do not think of it as medicine. It is just something from the drugstore. Carol was 73. She took lisinopril for blood pressure and a water pill for leg swelling. She also used ibuprofen several times a week for arthritis in her hands. She thought she was managing beautifully. Then her labs worsened. Her blood pressure became more erratic. Everyone scrambled to figure out what had changed. It was not a mystery. It was the interaction. And once the daily anti-inflammatory was removed, safer alternatives were reviewed, and monitoring was tightened, things improved. The lesson here is that some of the biggest medication dangers come not from rare side effects listed in tiny print, but from common combinations that nobody reviews carefully enough. If you take Losartan or lisinopril, over-the-counter pain medicine is not a casual topic. It is a serious safety conversation. The next issue is the one people laugh off until it becomes a fall. Dizziness, lightheadedness, that woozy moment when you stand up too fast, the unsteady feeling after the first few doses of a new medication or a dose increase. With all three of these medications, your body may need time to adjust to lower blood pressure. That adjustment period can mean dizziness, especially when moving from lying down to standing. People dismiss it. They say they just got up too fast. Maybe that is all it is. But in older adults, a few seconds of dizziness can become a fractured wrist, a head injury, or a broken hip. Joseph was 80 and prided himself on independence. He lived alone, moved carefully, and hated asking for help. 2 days after starting a higher dose of amlodipine, he stood up in the bathroom in the middle of the night and felt the room tilt. He grabbed the sink just in time. He did not fall, but it scared him. When I asked whether anyone had warned him to rise slowly, sit on the edge of the bed first, and watch for persistent weakness or near fainting, he shook his head. He had been told the medication might lower his pressure. He had not been told what that might actually feel like in a real body moving through a real house in the dark at 2 a.m. That is the difference between prescribing a drug and preparing a patient. Mild initial dizziness may improve as the body adapts, but fainting is not something to ignore, and repeated dizziness is not something to silently endure. The next mistake is one that intelligent, health-conscious people make constantly. They look at a single blood pressure reading, see a high number, and conclude the medication has failed. Or they see a single low number and decide the medication is too strong. That is not how blood pressure works. Blood pressure fluctuates constantly. It changes with sleep, pain, stress, conversation, posture, meals, caffeine, hydration, and anxiety about the reading itself. A single number is not a verdict. It is a snapshot. What matters is pattern. Diane was 67 and checked her blood pressure every time she felt worried. If she had a headache, she checked. If she read something stressful, she checked. If she got a high reading, she checked again 2 minutes later. Then again. Then again. Until she had a page full of numbers and a heart full of fear. She was convinced her Lisinopril was not working. But when we slowed everything down, used the same times each day, and had her rest quietly before measuring, a very different picture emerged. Her medication was working reasonably well. The chaos was in the method, not the medicine. Medications like Amlodipine, Losartan, and Lisinopril should be judged by trends, not by single panicked readings. The next point is about timing and consistency. These medications work best when taken consistently. Same general time, same routine, same system. If you miss a dose, the answer is not usually to double up later. Many standard instructions say to take the missed dose when you remember, unless it is close to the next scheduled dose. If it is close, skip it and resume the normal schedule. Do not take 2 doses at once unless specifically instructed by your clinician. Yet, people do this all the time. They are afraid of their blood pressure climbing, so they try to catch up. And then they feel dizzy, weak, or frightened by a drop they caused themselves. Blood pressure medications are not rescue pills for random spikes. They are long-game medications that work through steady, consistent use. If you do not know what to do when you miss a dose, ask. If you are not sure about timing, ask. Guessing with these medications may feel small in the moment, but it can create very real problems. And now, the most important point of all. The best blood pressure medication is not the one that gives you the prettiest number for 3 weeks. It is the one you can stay on safely, consistently, and intelligently because it fits your body, your symptoms, your other conditions, your lab results, and your actual life. That is the truth people miss. A medication can look successful on paper while failing in the real world. Because you hate how it makes you feel. Because you do not understand its warning signs. Because you have quietly started avoiding it. Amlodipine may work beautifully for one person and cause miserable swelling for another. Lisinopril may protect kidneys and control pressure wonderfully, but a dry cough can destroy sleep. Losartan may be a great alternative, but it still demands respect for potassium, kidneys, and hydration. Let me tell you about Teresa. She was 70 and had excellent blood pressure numbers on Lisinopril. Any clinician glancing at her chart would have been satisfied. But Teresa was coughing every night, sleeping terribly, beginning to dread the pill. She did not tell anyone because she assumed the answer would be, Well, you need it, so just live with it. That assumption is where patients disappear from good care. First, they resent the medication. Then they start forgetting it on purpose. Then they stop it entirely. Then the blood pressure rises again and everyone acts surprised. Teresa did not need a lecture. She needed a medication plan that fit her actual body. Once the cough was identified as likely medication-related, her clinician was able to reassess and adjust. That is good care. Not push through at all costs. Not suffer silently because the numbers look nice. Real care means the person matters as much as the pressure reading. Side effects are not personal weakness. They are clinical data. Swelling is data. Cough is data. Dizziness is data. Weakness after dehydration is data. Palpitations, lightheadedness, fatigue, muscle cramps when potassium shifts, all data. Your job is not to diagnose yourself. Your job is to notice the pattern and report it. Too many people think being a good patient means never complaining. That is completely wrong. A good patient pays attention. A good patient speaks up early. A good patient does not wait until their throat is swelling, their kidneys are struggling, or their blood pressure is uncontrolled because they quietly stopped the medicine 3 weeks ago without telling anyone. Silence is not strength here. Silence is risk. So, let me give you the practical framework I want you to remember every time you take amlodipine, Losartan, or Lisinopril. If you take amlodipine, watch for ankle swelling, flushing, headaches, dizziness, and that heavy leg feeling by evening. If you take Lisinopril, watch for a persistent dry cough, dizziness, and especially any swelling of the lips, tongue, or throat. If you take Losartan, watch for dizziness, weakness, illness-related dehydration, and signs that potassium may be drifting too high. Muscle weakness, cramping, tingling, pins and needles, or an irregular heartbeat. With Losartan and Lisinopril especially, blood tests matter. With all three, consistency matters. And with every single one of them, a symptom you cannot explain is worth discussing. You do not need certainty to make a phone call. You only need a pattern that concerns you. Not every side effect means catastrophe. Mild headache when starting amlodipine may improve. Mild dizziness when first lowering blood pressure may settle as the body adapts. A dry cough on Lisinopril can be bothersome without being dangerous. But not every side effect should be endured indefinitely either. There is a real difference between, "This may improve in a few days," and "This is stealing my quality of life." The answer is not panic, and it is not denial. The answer is interpretation. And interpretation gets better when you know what class of drug you are taking, how it behaves, and what red flags cross the line from nuisance to urgency. Once you understand the mechanism, so much of the fear dissolves. You stop imagining that every symptom means the worst, and you stop pretending that obvious symptoms mean nothing. That balance is where safety lives, not in ignorance, not in obsession, in understanding. I am Dr. Emily, and the most important thing I can leave you with is this. Your blood pressure medication is a tool, a powerful one. But like any powerful tool, it works best when you understand how it operates, what to watch for, and when to speak up. The seniors who stay safest on these medications are not the ones who never experience side effects. They are the ones who recognize them early, report them clearly, and work with their clinician to find the approach that fits their body, not just their numbers. If this was helpful, share it with someone who takes blood pressure medication, because there is a very good chance they need this information and have never received it clearly. Take care of yourself, and take your medication seriously, not fearfully.